The final stages for closure of the transoral approach will be summarized here. The nasal pledgets are now removed. The endotracheal tube is freed from the lateral retractor and moved to the midline. This is important for passage of the nasogastric feeding tube via the left nostril into the pharynx and then into the esophagus, which should be to the left of the endotracheal tube. The nasogastric tube is now secured to the midline column of the nostril, and the position of the nasogastric feeding tube is confirmed by the anesthesiologist, auscultating over the stomach and insufflation of air into the NG tube to make sure that the tube is in proper position. This will require between 60 to 70 centimeters of visualized tube in the high nasopharynx. The posterior pharyngeal closure is now layered with flow seal and covered with a blanket of gel foam. Soft palate closure is accomplished by bringing the nasal mucosa together, starting at the apex. As before, this is done with interrupted sutures of 3O polyglycolic, with a knot being preserved towards the palatal musculature. As one proceeds towards the uvula, the reconstruction should be carefully approximated. The oral mucosa of the soft palate approximation includes muscular tissue underneath, using vertical mattress sutures. The muscular tissue must be approximated with the oral mucosa so as to prevent a palatal dehiscence. This is an important step. The stay sutures are released in a stepwise fashion. The oral mucosa of the mouth, as well as the soft palate, is now smeared with 1% hydrophilic ointment with hydrocortisone, and this includes the tongue. Finally, the postoperative images show decompression of the ventral medulla and subsequent dorsal occipitocervical fusion.